we're talking about tyrosine kinase inhibitors, right? I know we spoke about Philadelphia chromosome and that whole idea of how the chromosomal translocation produces a tyrosine kinase that normally does not exist, right? So to take a step back and get our heads back in the game, because it was a week, because of President's Day, we had that break. We are talking about anti-neoplastic drugs, right? And we know that the evolution of therapy for cancer begins with surgery, then radiation, then the conventional chemotherapeutic drugs that we discussed, such as the alkylating agents and the anti-metabolites. And we have now moved on to targeted agents, and we're going to finish up today with some very exciting information about immunotherapy, biologicals, things like that. I went over the trick for identifying something about the mechanism of action of a drug just from its name. So you know that if you see a drug called Gefinitiv, you know that it is a tyrosine kinase inhibitor. And again, the point of these targeting drugs is unlike the original chemotherapeutic agents that have this tremendous toxicity, right? Because the rationale for drug design when drugs became a thing for cancer, right? Initially there were no drugs. It was all about surgery and radiation. But when drugs became a thing, the original rationale was, hey, let's target cells that are replicating rapidly, because that's what cancer cells do. That was somewhat effective, but we also understand that there are normal cells in the body that are active on the cell cycle that replicate rapidly, and hence there are tremendous toxic effects of the conventional chemotherapeutic agents. So these targeting agents target specific abnormalities of the cancer cells that are not present in normal cells, and thereby have many fewer what's called off-target effects, right? Much less toxicity, right? And many of the original targeting agents targeted tyrosine kinases, and they were tyrosine kinase inhibitors. And just to remind you, a tyrosine kinase is an enzyme that adds a phosphate group to a protein. There's such a thing as kinases that autophosphorylate. So I was about to say to another protein, or in fact the same protein. And by so doing, it generally increases the activity of that protein. In cancer, many times the protein that is phosphorylated by the tyrosine kinase is something related to cellular growth. So a growth factor or a growth factor receptor, right? So gefitinib is an example. It is an inhibitor of the tyrosine kinase that activates epithelial growth factor receptor, a growth factor receptor, okay? And we can march through, we're now marching through, some of these tyrosine kinase inhibitors that inhibit these specific tyrosine kinases that are abnormally upregulated, right? So here's the concept of oncogene. We all have tyrosine kinases that activate epithelial growth factor receptor, that activate growth factors and their receptors in our body, because to some extent we need for our cells to grow and replicate. It's just that a cancer cell has an abnormal form or an abnormal amount of that tyrosine kinase, and cell growth has gone wild, right? Okay. Now, I want to talk about, Sunitinib is another example of one of these targeting drugs. I actually want to talk about this one for a minute because it introduces a novel concept in targeting, right? So sunitinib targets something called vascular endothelial growth factor. And this was a revolutionary idea. Imatinib was the original VEGF inhibitor, and then sunitinib was the sort of second generation VEGF inhibitor. And I think I mentioned this idea last time. The idea is that these tumors produce their own blood supplies, right? So if you've ever seen a large tumor, you may notice that the center of the tumor is sometimes soft and necrotic. That's because the tumor cells, the cancer cells, grow so fast that they may outgrow the blood supply. And if the cancer cells are not supplied with oxygen and ATP and energy, nutrients, glucose, all those things that they need, the cancer cells won't survive. So the cancer cells are very clever, and they have machinery to produce their own blood vessels to transport blood to their cells as needed. This process is called angiogenesis, and it's directed by vascular endothelial growth factor, and vascular endothelial growth factor, or VEGF, of course, has its own receptor, the VEGF receptor, or VEGFR. And this is the target of both imatinib. Trade name for imatinib, by the way, is Gleevec. You may have heard it, and its successor, sunitinib. So those are pretty revolutionary developments in targeting therapy in cancer that you should know about. Then we have some others. Those two, I would say, are very important. Yes, the last slide in this packet has the drug list, you know, the ones for which you are responsible for, but in my mind, those two targeting agents are quite important. We have others that came along, crizotinib, which targets anaplastic lymphoma and non-small cell lung cancer. Another protein kinase inhibitor. Side effects to remember for this one is vision problems, that crizotinib sometimes causes blurred vision. And there's yet another one, vemurafenib, which specifically inhibits BRAF and is specifically useful for melanoma. Side effects, joint pain and skin rash, on and on, right? So once, you know, this this approach was discovered to be useful, this targeting approach, tyrosine kinase inhibitors, different companies got into the game, and everybody made a tyrosine kinase. So Johnson and Johnson made one for a particular type of lymphoma called mantle cell lymphoma, which is a subtype of CLL, chronic lymphocytic leukemia. Remember, we talked about chromosomal translocations and the famous BCR-ABL Philadelphia chromosome translocation, and how that chromosomal translocation produced a tyrosine kinase that normally doesn't exist, only exists in the cancer cells. Well, there are other chromosomal translocations, chromosomal deletions, chromosomal abnormalities that can occur, and there is a chromosomal abnormality which involves a deletion of chromosome 17 in CLL. That produces a particular tyrosine kinase. This drug, ibrutinib, targets the tyrosine kinase that is activated when a cancer cell has this chromosome 17 deletion, and that occurs in CLL. Another one is trade name Tagrisso or osimertinib. Again, yet another tyrosine kinase, EGFR tyrosine kinase inhibitor. So again, to remind you, the tyrosine kinase is phosphorylase epithelial growth factor receptor. That makes epithelial growth factor receptor do more. It activates epithelial growth factor so that cells grow more quickly. We all have this tyrosine kinase in our body, but cancer cells have mutated forms, right? You don't have to memorize the mutations. It's just, it would be enough to know that this drug is a tyrosine kinase inhibitor that targets the EGFR tyrosine kinase. And that's all you need to know. I wouldn't ask you to recite the mutation. But that's the general theme of many of these. Novartis came out with an inhibitor called the CDK4/6 inhibitor, particularly useful for advanced breast cancer. We'll be talking a little bit about HER2 and that receptor and what all of that means. This one is not a tyrosine kinase inhibitor. This is a different type of kinase inhibitor, a cyclin-dependent kinase, but basically same idea. The inhibitor prevents a kinase from activating other proteins that enhance cancer cell growth. Yet another one, and I'm going through these a little bit quickly because I think it's repetitive and I don't want to spend oodles and oodles of time on memorizing the details of each one. I think the underlying concept that this is targeted therapy, that these are small molecules, that they're generally tyrosine kinase inhibitors, that they inhibit these tyrosine kinases that phosphorylate and activate proteins that are involved in cellular growth. That's the take-home message. That's what I want you to know about these guys. Abemaciclib, trade name Verzenio, is yet another one used for metastatic breast cancer. Zejula. Zejula is a little bit different. It is not a kinase inhibitor or a tyrosine kinase inhibitor. It is a PARP inhibitor. Poly-ADP ribose polymerase is a complicated molecule that is involved in many different molecular pathways and involved in cellular growth and replication. So this one stands out for not being a kinase inhibitor, but it is a PARP inhibitor that might be worth knowing. Zejula, niraparib is a PARP inhibitor. Okay, and this is sort of a summary statement of kind of, what we've looked at. The FDA approved many different therapies, notably for small cell lung cancer and non-small cell lung cancer. It goes on and on to talk about specific treatments, urothelial cancer, colorectal cancer, new therapies. Again, I wouldn't worry too much about this FDA statement. The bottom line is that as recently as 2020, the FDA approved a bunch of novel targeting drugs, right, to address the problem of these cancers for which we still did not have good therapy, or the therapy that we had tremendous toxicity. So there is this great wave of new drug therapy that comes about, even now, drug companies are still coming out with novel targeting agents to address these cancers that were not well treated by the chemotherapy agents. I mean, I want to emphasize that if we look over time, the evolution of drug development for cancer is quite remarkable, right? From going back to the time where all we had was surgery and radiation. If we think about a disorder like acute lymphoblastic leukemia, that was essentially a death sentence before maybe 1970 or so, and then with the advent of even the conventional therapeutic agents, right, like the anti-metabolites, the prognosis was so much greater. These new targeting agents came in a rush, and the FDA approved many of them in an attempt to have novel therapy for the resistant cancers that we couldn't treat. Non-small cell lung cancer was particularly difficult, and so capmatinib was an agent that came out specifically, or Tabrecta it's called, specifically for non-small cell lung cancer. I want to know about that. And then metastatic small lung cell cancer, an agent came out, Zepzelca, lurbinectedin. Again, these were targeting agents that targeted specific molecules in these particular cancers. Okay, so that's all I want to say about targeting. You can see that I kind of quickly went through a bunch of slides there because I don't believe in memorizing drug name after drug name after drug name. I prefer that you understand the general concept, targeting therapy, tyrosine kinase inhibitor. What is a tyrosine kinase inhibitor? What is it inhibiting? What, what does epithelial growth factor receptor have to do about all this? No, I would know something about imatinib and sunitinib as special agents that inhibited angiogenesis. That was a revolutionary concept that came out a couple of decades ago, that if we could block angiogenesis, or neovascularization, it can also be called, we can cut off the cancer tumor's blood supply, and that was a novel idea. So a tyrosine kinase inhibitor was approved by the FDA for both GIST, which is a gastrointestinal stromal cell tumor, GIST, and CML, and chronic myelocytic leukemia. This drug is, does anyone know? Imatinib. And then sunitinib came out after imatinib, and sunitinib is sort of the second generation drug that was meant for cancers that were resistant to imatinib. And imatinib, trade name Gleevec, again, that has that really cool mechanism of inhibiting angiogenesis. Okay. So I just gave away the answer. A tyrosine kinase inhibitor was approved for imatinib-resistant tumors, and that one is sunitinib. So imatinib is the first generation, and then for cancers that were not treatable by imatinib, the choice was sunitinib. So that's worth knowing. I would say, know what definitive is, know what olatinib is, know what sunitinib is, know what imatinib is. It sounds like gobbledygook, doesn't it? But know about those four drugs, which are EGFR, tyrosine kinase inhibitors, which inhibit which affect VEGF and angiogenesis. Okay, yes.
I just want to make sure. You said that sunitinib, I'm saying that right?
Yeah.
That is for chronic lymphocytic leukemia, correct?
Yeah, I think so. Yes. Yeah. Well, they both imatinib and sunitinib are CML. I think chronic. I think it's chronic myelocytic leukemia. Actually, CML. Yeah. Thank you. Yes. Okay. Great. Good question. All right. The last portion of this unit is sort of interesting and exciting, and I want to focus a little bit more on it because it is the cutting edge of anti-cancer therapy, right? I'm going to say it again. Surgery, radiation, conventional chemotherapeutic drugs, targeting chemotherapeutic drugs that we just discussed, and the fifth arm of your cancer therapy is immunotherapy. Ooh, there's a typo. Immunotherapeutics. It's supposed to be P, not please. Right, immunotherapy. And immunotherapeutic agents for cancer can be divided into perhaps two classes. One is antibodies, monoclonal antibodies, and another is biologic response modifiers. And so we'll talk about that. Okay. You don't really have to know how to make monoclonal antibodies, but basically they are made with the help of a mouse. And I actually made some for my PhD project long ago, which ended up not being usable, but I have some experience. So what happens is you take a mouse cell, you immunize a mouse, and then you isolate a mouse B cell, or a B cell from that mouse that is producing a specific type of antibody, and you grow up that cell, and you find a way to amplify that one particular cell. You make a hybrid, something called a hybridoma. You implant those hybridomas into mice. So it's a way of amplifying one particular antibody. So that's why they are monoclonal antibodies. You make an amplified clonal population of B lymphocytes, all of which produce the same antibody. So if I know that a particular antibody is going to target an antigen that is produced by a cancer, but not produced by normal cells, that might be a very valuable tool for anti-neoplastic therapy, right? So that's the whole idea of monoclonal antibody therapy. Monoclonal antibodies are very specific. They are all the same. They all target a particular antigen. Okay. Radiation is sometimes combined with monoclonal antibodies. Remember that we talk about these different anti-cancer modalities: surgery, radiation, conventional chemotherapy, targeting chemotherapy, and now immunotherapy. We talk about these 5 arms as if they are in 5 silos. They are not, as you know, that they are combined. Somebody might choose to perform chemotherapy before surgery in order to shrink a tumor. And radiation has been effectively combined with monoclonal antibodies. Monoclonal antibodies can also be combined with biological response modifiers. I'm going to explain what biological response modifiers are in a minute. Okay, and there are other applications. So now, how do these monoclonal antibodies work? Okay, we all have a general idea that antibodies target antigens, and when they bind to these antigens, presumably they somehow neutralize the cell that expresses the antigens, right? Well, there actually are specific, what are called antibody effector mechanisms. In other words, when a monoclonal antibody binds to, let's say, an antigen that is expressed on a cancer cell, there are a number of pathways that can be activated. You have antibody-dependent cellular cytotoxicity. So that means that there are specific cells, over here, that there are specific cells that are in the circulation, and they're circulating around, and when they see that a monoclonal antibody has attached to the tumor cell antigen, these circulating cells, such as the natural killer cell, recognizes this situation. The monoclonal antibody is attached to the tumor antigen, swoops down out of the circulation, interacts with the monoclonal antibody which is sticking out, and thereby destroys the cell. Okay, so that's antibody-dependent cellular cytotoxicity, ADCC. The monoclonal antibody binds, the circulating natural killer cell detects the bound monoclonal antibody, swoops in and destroys the cell. Another possible antibody effector mechanism is CDC, complement-dependent cytotoxicity. It's kind of similar. You've all heard about the complement system, right, which complements the other branches of the immune system, right? So that's not new, the complement cascade. So sort of a similar idea. When the monoclonal antibody covalently binds to a tumor cell surface antigen, the complement cascade is activated. And the complement cascade, you'll recall that the terminal steps of the complement cascade are insertion of the membrane attack complex, remember that business, C5 through 9, and lysis of the cell, right? So all that you need to remember is that one of the possible antibody effector mechanisms when we're talking about monoclonal antibody therapy for cancer, one of the possible mechanisms is complement-dependent cytotoxicity. The complement is activated, and that kills the cell. And then finally, the third antibody effector mechanism is antibody-dependent cellular phagocytosis, which will involve a phagocyte, such as a macrophage. Right? They're all pretty similar. They all have to do with something in the circulation recognizing that the monoclonal antibody has covalently bound the cancer cell surface antigen. For ADCP, antibody-dependent cellular phagocytosis, the antibody has bound to the tumor cell antigen, the circulating macrophage sees that monoclonal antibody flapping in the breeze, swoops in, forms a complex with the monoclonal antibody that's bound to the cell, and engages in phagocytosis. Right? Yes.
For the ADCC pathway,
Mhm.
when you were talking about the natural killer cells and how they interact with the monoclonal antibody, is that the signal for it to destroy the tumor cells, or is it destroying the monoclonal antibody?
No, the whole cell.
The
This
whole
is
cell.
all to destroy the whole cell.
Okay.
Yeah. So it will like interact with the complex of the monoclonal antibody binding to the cell surface antigen, and then the whole cell is destroyed. Lysis. So the whole cell is burst. So if a macrophage is involved, the tumor cell is phagocytosed. It's engulfed, and then it's chewed up inside the cytoplasm of a macrophage. For the other two mechanisms that I discussed, if a natural killer cell is involved or complement is involved, the tumor cell is lysed. That means it explodes, it's burst, right? And the natural killer cell will actually mediate the lysis of the tumor cell. It will release factors that will cause the tumor cell to explode. And complement, of course, the complement cascade, of course, terminates in the membrane attack complex, which destroys the plasma membrane of the tumor cell and also causes the tumor cell to explode. So great question, but so these are all ways that the monoclonal antibody ultimately causes the cancer cell to die, either to be phagocytosed or to be lysed. Okay, cool. We have some monoclonal antibodies to talk about. Again, you know me, I'm not big on like lists and names. I'm bigger on concepts, but I guess we need to know that the first monoclonal antibody to be approved for cancer was rituximab, trade name Rituxan. Rituximab, it's good to know, sort of historically, chimeric monoclonal antibody just means that it was an antibody that was made by hybridizing mouse parts and human parts. That's what a chimeric monoclonal antibody is, so that from the mouse, we get the convenience of being able to amplify the B cells that produce high numbers of antibodies, and then for the human part, we get compatibility with human hosts. So it's directed against a protein called CD20, which is on the surface actually of both normal and malignant B lymphocytes. But the thing is that in certain cancers, in CLL, in chronic lymphocytic leukemia, patients have super high levels of B lymphocytes. So, I mean, the problem with this is, again, it also targets normal B lymphocytes, so it might cause lymphopenia, right? And it might leave the patient a bit susceptible to infection. But it was a monoclonal antibody directed against CD20, which is expressed on B lymphocytes. And so it was used for patients with CLL. So that's good to know. And it was sometimes combined with some other drugs. Okay, so rituximab, let's remember that one as the first monoclonal antibody. Here's a really interesting one that comes along. Herceptin comes along in 1998. Herceptin is the trade name. The other name is trastuzumab. Oh, remember your nomenclature, right? All of these, you may notice that all of these drugs now end with MAB. Ooh, what does MAB stand for? Monoclonal antibody, right? So if you're on an exam and you're going, oh man, is this one a monoclonal antibody or a tyrosine kinase inhibitor? Oh, I don't know. Oh, wait, man, monoclonal antibody. No need to panic, stay calm, and you'll figure it out. Okay, so this one comes along and is really revolutionary for patients with metastatic breast cancer. So you may have heard, one concept that I don't know that we discussed very much is that cancer cells may express different surface proteins, different surface antigens. Breast cancer cells are famous for that, right? There are 3 surface antigens that breast cancer cells are known to express or not express estrogen receptor, progesterone receptor, and HER2 protein. Actually, in general, if breast cancer cells express these proteins, it gives one a hook. It gives one a target for therapy. The most difficult, everything being equal, the most difficult type of breast cancer to treat is so-called TNBC, which stands for triple negative breast cancer. That means breast cancer that expresses none of the 3 common surface antigens that breast cancers express. So HER2 is a protein that is expressed by some of these breast cancers, and a monoclonal antibody dubbed Herceptin was created in 1998 that was very effective for patients who had breast cancer that expressed HER2 protein. And it happened to be administered in combination with Taxol. Taxol was considered one of the general chemotherapeutic agents, right? You'll remember that Taxol, what does Taxol do again? Remember the mechanism? It prevents depolymerization of the microtubules, right? It's one of those cell cycle specific agents that acts in M phase of the cell cycle. You don't realize how much we've learned already. But anyway, so HER2 monoclonal antibodies happen to be commonly combined with Taxol. Okay. Right, and the protein HER2 new is a tyrosine kinase. And so not only is it a marker on the cell surface of breast cancer cells, but it probably had some function as a tyrosine kinase, again, amplifying the growth of the cancer cells. Although I said that the worst type of breast cancer to have prognostically is triple negative breast cancer that expresses none of the 3 antigens that are commonly expressed on the cell surface of breast cancer cells: estrogen receptor, progesterone receptor, and HER2 protein or HER2 new protein, and that's true. But expression of HER2 protein itself is a bad prognostic indicator. The best type of breast cancer to have in terms of treatability is breast cancer that expresses estrogen and progesterone receptors. Because HER2 is an oncogene, it's a tyrosine kinase, it promotes faster growth of the breast cancer cells. So this Herceptin, this monoclonal antibody, was very effective in inhibiting the tyrosine kinase function of HER2, and also in destroying the cells. Right? Remember, here's one of our mechanisms of monoclonal destruction, right? If we go back, ADCC, right? Antibody dependent cellular cytotoxicity, right? So the monoclonal antibody against the HER2 protein binds to the protein, and natural killer cells that are floating around in the circulation come by, and they mediate cell lysis. So so now you can combine what you know about mechanisms of monoclonal antibody cell mediation with what you now know about Herceptin. Okay. All right, so I may have inserted a slide or 2 into the packet, don't panic, that was not in the original packet, so I'm not sure that this one is in the packet. It's posted on Canvas, but don't worry about it. I wanted to show this, though, to talk a little, just to give you some quick idea of the mechanism. So this HER2 protein that we're talking about, right, the way it actually acts targets. And yes, it is a protein that has tyrosine kinase function that activates all of these intracellular steps for which you are not responsible that ultimately results in cell cycle progression and proliferation, yes? But what I wanted to show here is the HER2 protein does something cool. It dimerizes. So it exists when it's not activated, it exists on the cell surface, expands the plasma membrane, and it hangs outside the cell surface as a single moiety. And then when it gets activated, when it gets ready to stimulate intracellular events that will culminate in activation of the cell cycle, when it gets ready to do all that, it dimerizes. So two different HER2 molecules come together. So I mention that because this mechanism could also be targeted as an anti-cancer mechanism, right? So you could have a monoclonal antibody that just binds to HER2/neu, and that could trigger natural killer cells to come swooping in and cause cell lysis, yes. But you could also have some agent or monoclonal antibody that specifically interferes with dimerization of HER2, and that would be another anti-cancer mechanism. Okay, so still talking about trastuzumab, which is the classic anti-HER2 monoclonal antibody known as Herceptin. A little bit of toxicity to worry about, infusion-related reactions, cardiomyopathy can happen, fever, chills, nausea, vomiting, like almost anything, and hypersensitivity, okay? Cardiomyopathy is probably the most important one to worry about, so patients with underlying cardiac issues must be cautious, or you must be cautious with administering Herceptin to patients with underlying cardiac issues. Okay. So moving on, so some other monoclonals. So those are sort of the important monoclonal antibodies. We have a couple more. There's one that binds to a protein called CD33, a humanized anti-CD33 monoclonal antibody that is particularly useful for patients with AML, acute myeloid leukemia, which is otherwise can be a very difficult disease to treat. So gemtuzumab or Mylotarg is for AML, a monoclonal antibody, and then Avastin. So Avastin is another very interesting drug that is another anti-angiogenesis drug, right? So we spoke about Gleevec, right, imatinib and sunitinib as drugs that target VEGF. Now we have a monoclonal antibody that does that, right? So Avastin is the first monoclonal antibody that is an anti-angiogenesis drug. So it actually targets VEGF. Remember, VEGF is an important molecule to know about, vascular endothelial growth factor, as the molecule that directs the formation of blood vessels, that directs the formation of new blood vessels. It does that under some different circumstances in the body, during development, during presentation, and in cancer. And so Avastin was big drug. I remember I arrived at St. John's in 2004, and it had been approved just months before I arrived. And people were talking about it, especially people who study cancer pharmacology over here. Avastin was a big new drug on the scene, a monoclonal antibody that targets VEGF. So it's not that it targets tumor cells, right? So it doesn't like bind to antigens on the tumor cell, like let's say Herceptin, right? That binds to HER2, which is sticking on the surface of a breast cancer cell. But it neutralizes VEGF. It stops vascular endothelial growth factor from doing its thing, which is producing new blood vessels that are going to bring oxygen and nutrients to the cancer cells. So Avastin is a very interesting monoclonal antibody. You should know that it targets VEGF and thereby prevents this process called angiogenesis for cancer cells. A couple more. So we have cetuximab, specifically for colorectal cancer. And again, these came out not so long ago. So I mean, 2004, I mean, it seems like a long time ago, but it's when I arrived on campus as a new professor, it seems like yesterday. And that's when some of these drugs came out. So cetuximab is a monoclonal antibody for colorectal cancer, and it targets our old friend EGFR, right? So EGFR, right, we target that in different ways, right? So remember, there were all of those tyrosine kinase inhibitors that inhibited the activation of EGFR by tyrosine kinases. That's one way. Now we have a monoclonal antibody that is an antibody that binds to EGFR, that sticks to that pesky receptor, which is so important in cellular growth in cancer. So two different mechanisms whereby EGFR is targeted: tyrosine kinase inhibitors and monoclonal antibodies. Okay, let's see. I know we're getting. I'll just go. I think there should hopefully only be a couple more slides. I'm not sure, but I'll stop. Let's see. How many more do we have? Maybe we'll. I know people are getting a little bit glazed over. Okay, so we'll stop. Maybe we should stop here. It's 4:12. Time for our break. Okay, we'll definitely finish this packet after break, and we'll.